Hi everyone, my name is Ashley Jenkins, here to report my Dayton Children's Hospital Inpatient Behavioral Health Program evaluation. So the Inpatient Behavioral Health Unit serves children experiencing mental and behavioral health crises that can't be safely managed at any lower level of care outside of the hospital. The unit accepts patients that are 9 to 17 years old physically with an even wider range of cognitive functioning. So for example, I worked with a kiddo who was 12 years old but actually functioned at the level of a 6-year-old. Clinical presentations and diagnoses often include suicidal and or homicidal attempts preceding hospital admission, suicidal and or homicidal ideations with or without a plan, behavioral disturbances, moderate to severe depression or anxiety, auditory or visual hallucinations, manic episodes, and psychosis. Additionally, many patients present with comorbidities such as substance abuse, eating disorders, attention deficit disorder, autism spectrum disorder, and learning disabilities. Precipitating factors for the patient's crises are often rooted in severe social environmental stressors outside of the hospital, such as peer conflict, bullying and teasing at school, academic-related stress, caregiver-child and other family relationship conflict. And then a lot of these kiddos have very extensive histories of abuse, neglect, and abandonment and are in either the permanent or temporary custody of the state or alternative non-biological caregivers. And that's very sad and constantly feeds into their mental and behavioral symptoms and overall emotional well-being as well. Lots of the kiddos we work with are exposed to violence, substance abuse, and an array of criminal behavior outside of the hospital as well. The inpatient behavioral health programming is multifaceted. It's rooted in crisis stabilization, therapeutic interventions, medication management when appropriate, patient and caregiver education, safety planning, and discharge planning. The average length of stay for our program is 3 to 5 days, and this depends on a variety of factors, such as the individual patient's treatment progress and their associated clinical presentations, the recommendations from various treatment team members, risk and protective factors, patient and caregiver participation in treatment and feedback, and the individual financial circumstances of each patient. The interventions that are utilized in our programming include various talk therapy treatment modalities, art therapy, music therapy, movement therapy, animal therapy, all of which there's heavy emphasis on coping skills education and safety. Medication management services are determined on a case-by-case basis as well. And then the interdisciplinary team on the unit consists of psychiatrists, psychiatric nurse practitioners, behavioral health therapists, nurses, mental health technicians, patient care technicians, and other specialists from other areas of the hospital as needed. For the purpose of this evaluation, I focused on coping skills education efforts specifically, since it seems like every staff member, regardless of what capacity you work in behavioral health, each interaction is meaningful and that we're constantly hammering in coping skills education and practice with patients, because we can't necessarily change their social environmental circumstances outside of the hospital, but what we can do is equip them with the skills necessary to manage those stressors when they leave us in a healthy manner. So I broke the coping skills down into categories and looked at activities, coping skills, mindfulness, and cognitive coping skills. So for my evaluation questions, I wanted to know, are inpatient behavioral health programming efforts improving patient knowledge of healthy coping skills? And if so, what categories of coping skills are these patients learning? As a behavioral health therapist intern, a large part of my role with the unit is to meet with new patients on my caseload within 24 hours of their admission to complete psychosocial assessment and treatment planning activities. I then meet with those same patients again on day 3 to 5 of their stay for safety planning and discharge preparation activities. So a program level evaluation, single group, pre-test, post-test design was identified as the best fit for my specific field circumstances. A single case design didn't seem feasible due to the high frequency of patient turnover every 3 to 5 days. My data source consisted of 33 inpatient behavioral health unit patients. Use of probability sampling ensured that each patient had an equal chance of inclusion in my evaluation with random selection absent any bias. Um, my data collection strategy included one-to-one pre-test, post-test interviews with patients during already existing assessment activities that naturally occurred within my workflow. So I didn't have to add in any new interactions to complete my evaluation, which really made this evaluation very convenient. So the outcome that I measured was coping skills knowledge. And in regards to the measurement tool, I browsed so many rapid assessment instruments and I could not identify an existing tool that was completely relevant to my evaluation or appropriate to the time that I had with patients during my interactions. So I decided to develop an anchored rating scale of my own. According to the Ohio State University Module 12 coursework, the anchored rating scale provides the opportunity to employ a more individualized approach to measurement efforts, and it helps when tracking subjective items such as moods, emotions, thoughts, and other internal behaviors that are difficult to observe objectively. So, knowledge of coping skills is definitely difficult to observe objectively. So one of the benefits of the anchoring component of the scale that I developed is that it promotes consistency and improves reliability and validity of my data collection efforts. For my anchored rating scale, the number of coping skills named by the patient was directly anchored in that same number, and I used numbers 0 to 5. And then for any number of coping skills greater than 5, that was anchored into the number 6. When I met with new patients individually on day 1 to complete psychosocial assessment treatment planning activities, I asked patients to name as many coping skills as they know in that moment. And then when I met with the same patients again on day 3 to 5 of their stay for safety planning and discharge preparation activities, I re-asked the same question to assess for changes in their level of knowledge. So as patients name the coping skills that they know on day 1 and again on day 3 to 5, I tracked the quantity and the quality of the coping skills that they named on an Excel spreadsheet in one of the following columns. I had pre-activity coping skills, pre-mindfulness, pre-cognitive, and then post-activity, post-mindfulness, and post-cognitive. Specifically, I entered the number of coping skills named by the patient into the corresponding categorical column. So for example, if a patient named reading a book, eating a snack, and exercising as the only 3 coping skills that they knew during the pretest, I would enter number 3 into the pre-activity coping skills column since they named 3 activities coping skills. If that same patient named reading a book, eating a snack, exercising, taking a bath, redirecting negative thinking, and completing a body scan as the coping skills that they knew during the post-test, I would then enter the number 4 into the post-activity coping skills column, number 1 into the post-mindfulness coping skills column, and number 1 into the post-activity coping skills column. So immediately I can see whether the program's education efforts were effective, and also I can see the quality of the coping skills that each patient learned. This is a copy of the anchored rating scale that I developed. So in the left column is 0 to 6. So if the patient denied having any knowledge of coping skills at all, I would anchor that in the number 0, and then so forth all the way down to number 6, which means that a patient named greater than 5 coping skills. So in regards to data analysis, I manage my data with an Excel spreadsheet that I kind of referenced earlier. The Excel rows were the patient number, and there were 33 patients in total. The Excel columns were coping skills categories that I referenced earlier, and then I entered the pretest and post-test scores per the anchored rating scale table. In regards to data analysis, the statistical procedures that I used to analyze the data were the one sample t-test and Cohen's d effect size calculation. The one sample t-test was organized to analyze the data that I gathered against an assumed national average at scale by using the anchored rating scale pretest knowledge score to establish an individual rating for each participant. So the average of the individual ratings creates a control group that was necessary to evaluate the post-test knowledge score. Essentially, at scale, the 33 evaluation participants represent the average pretest knowledge score of the national population for pre and patient behavioral health program participants. So I had to do that, establish a control group, establish an average to develop a control group in order to statistically apply this procedure to my data. So the sample was validated by using null and alternative hypotheses based on the significance level and chance sampling calculation. The sample data was validated by accepting or rejecting the null hypothesis based on whether the chance sampling was higher or equal to the significance level. So all sample groups resulted in an alternative hypothesis which validated the use of the one sample t-test. Additionally, by calculating the t-value, the study was able to use a standardized Cohen's d effect size calculation to validate the overall impact of the program itself. A Cohen's d effect size for each category of coping skills. The activity, the mindfulness, and the cognitive was calculated, and the Cohen's d for each of those categories of coping skills rated in the very large range for effect size, which I was pleased with. Right, so here, this figure 1, I just wanted to include a copy of my activity knowledge t-test, my mindfulness knowledge t-test, and my cognitive knowledge t-test. So this is a picture of the bar graph that I used to visually represent the data, the results of the data. So this is the difference between the pretest and post-test coping skills knowledge scores per category. So you can see clearly from this graph that the activity, the mindfulness, and the cognitive scores all improved from the time of admission to the time of discharge. So this graphical representation of the data reinforces the inpatient behavioral health program success with coping skills education efforts. So for conclusions, in regards to results, the data analysis supported program level effectiveness, and it demonstrated clinically significant improvement in patient knowledge of healthy coping skills in the evaluated coping skills categories. In regards to implications, I found that increased patient exposure to mindfulness and cognitive coping strategies may further improve program level effectiveness because they didn't experience as large of a jump as the activity coping skills category did. So there's room for improvement there. And then further evaluation may be needed to determine perceived self-efficacy in relation to transforming new knowledge into relevant use. So I was able to see how much the patient learned, but I wasn't able to see, are they able to apply that? Do they feel comfortable applying that in everyday life? So that would be very useful to know moving forward. Incorporation of evidence-based instruments into workflow in general may augment future program and clinical evaluation efforts. So kind of like how I had to create the R's, there wasn't any existing tools or instruments that the inpatient behavioral health program is using to kind of evaluate their treatment or the patient's treatment progress. So I feel like incorporating that would be good for evaluations and just in general to see how patients are doing and have something more concrete to base that on. And then evaluation regarding patient recidivism may be of value. So these patients are learning all of this coping skills knowledge. They're learning it, but are they retaining it? Are they staying out of the inpatient setting and being able to safely kind of maintain at a lower level of care, or do they keep coming back for additional crises? So that would be of value to know. And I think that in regards to like my struggles or anything that I would change, I mentioned earlier my ARS or my anchored rating scale stopping at 5 and then having number 6 represent greater than 5, I definitely would have changed that. I did try to use the McMenner test initially as my statistical procedure, just to incorporate like the percentage of change from admission to discharge, but I didn't feel that that sufficiently displayed the level of change in each category. The change was seemingly small for the McMenner, but then when I applied it into the t-test, it displayed that a lot better. So I guess other than that, I am impressed with kind of what I learned from this experience, and I hope that when I share this with my field placement site that they'll be impressed as well. And all right, that concludes my presentation. Thank you.